very good afternoon. Today I am today I am going to discuss about a patient, 87-year-old female patient who came to us with blurring of vision in her left eye for 1 month, and she is a known hypertensive for 2 years, and she had a history of 2 anti-VEGF injections given. So this was the right eye, BCVA was 612, and the left eye 660. And in the left eye, as we can see, the posterior pole is there is a wedge-shaped distribution of intraretinal hemorrhage, and with macular involvement is there. So it's a clear case of BRVO, left eye supertemporal BRVO. So what should I do next? OCT or fundus fluorescein angiography. So in the 80s, when grid laser was the treatment of choice for the macular edema and OCT and anti-VEGFs were not invented, at that time FFA was the investigation of choice. But now OCT is the first and foremost investigation we should do. And FFA should be done when OCT was normal. So this patient with 660 vision, there is a macular edema, 1 month post anti-VEGF, vision improved to 660 to 624, and the macular edema came down, and in the 4 months follow-up, 3 anti-VEGFs was given, and there was nearly resolved hemorrhage along with the resolved edema. So now is the time to do fundus fluorescein angiography to look for the ischemia and capillary non-perfusion areas. So when we did the FFA, we saw the peripheral CNP areas and no leaking neovascularization was noted. Then sectoral laser was done. So this is the timeline of the clinical photograph of this patient in the 6 months period. So BRVO is the second leading cause of vision loss after diabetic retinopathy, and we should identify the risk factors, especially in the younger patient. There is various causes of vision loss. Either hemorrhage is sitting on the macula, there is macular edema, macular ischemia, there is neovascularization, there is complications which is hemorrhage. So when BRVO study was there in the 1984, grid laser was the treatment of choice and sectoral laser was done if NV is present. But now we should not wait for the NV to develop, because and we should go for the laser for the stabilization of the edema, to not rebound edema should not be there, and to decrease the number of injections in these patients. So now the first treatment of choice is either steroid or anti-VEGFs. These are the FDA approved steroid. In the steroid category, there is triamcinolone acetate, Ozurdex, and in the anti-VEGF category, we have ranibizumab, aflibercept, faricimab, and biosimilars. So the take-home message is identify risk factor, macular edema is present, consider early treatment, extensive CNP areas, do sectoral laser, look for complication, and save the other eye. Thank you.
Thank you very much, Dr. Bhanu. PRIYA, one question from the panelists. Anything you would like to ask?
What is the drawback of Ozurdex versus the anti-VEGF?
Sir, yes. Sir, the Ozurdex, it can give rise to increase in IOP, and the cataract development is there more in the Ozurdex compared to the anti-VEGFs.
What about NV? Does it treat NV? Does it prevent NV, or anti-VEGF will prevent NV better?
Sir, anti-VEGFs will prevent, and Ozurdex will take care of the inflammatory part, basically.
Thank you very much.